Good morning, all. I guess I can just check my audio now. Is everyone able to hear me okay?
Morning, everybody. Darville. Welcome to the CME for PMH this morning. We are going to say a quick prayer and then I'm going to introduce the speaker for this morning. Thank you for joining us. Father, we welcome you to this meeting this morning. Open our minds to learning. Help us to use what we've learned today to better care for our patients. We ask this in your name. Amen. Okay, I'm excited today to be your host and to welcome our speaker. Dr. Rhanda Darville is going to talk to us today. She graduated medical school from the University of Technology in Santiago in the Dominican Republic, and then joined us at PMH from 2009 to 2014. And then she went on to do her pediatric residency at Rutgers in New Jersey. She also held the chief resident post at Rutgers from 2017 to 2018. And then she became a pediatric gastroenterology fellow at the University of Iowa in Iowa City. So she's just completed her pediatric gastroenterology fellowship and she's come home to the Bahamas. And we are happy today to have her present to us. Go ahead, Dr. Darville. Welcome.
Thank you so much, Dr. Bassett, and good morning, everyone. I think Dr. Halliday is working on getting another computer. He's going to assist me with advancing the slides. Dr. Halliday, are you back as yet? Okay.
Also,
Okay. So I'll just go ahead and start some general introduction, tell you a little bit about myself. First of all, I'm so happy to be back home. I'm very much a home girl. So this is such a treat for me and such an honor to be able to speak with you all this morning. And I wanted to talk a little bit about, just GI and why I decided to do this subspecialty. But several people have asked me so far why I did choose GI. When I did my internship and then later on became an SHO while at PMH, I put together a short list of pediatric subspecialties that were needed here in the Bahamas. General peds is my first love, but I realized that there were several subspecialties that we needed to have here at home, or looked like there would be a need for them. And so when I went on to do my residency training with that short list in mind, I kind of just decided to see which one appealed most to me, and that ended up being GI, gastroenterology. I love the subject matter. I found that I was drawn to it. And then I remembered, there were some patients I had seen at PMH who had kind of piqued my interest in GI. And so it was an exciting field for me to study, and I decided to pursue it in fellowship. And the training was intense, but it's so rewarding, and it was such a great experience. I'm happy to be back in general peds a little bit right now, but I can't wait to get to full GI service and practice here in the Bahamas and to see what the needs of our children are here. I mentioned that I was at PMH and I had such a strong background while there as an intern and as an SHO, amazing mentors and teachers. And let's see, Dr. Halliday, are you there? Thank you. I just would be remiss if I didn't mention some of the great people who mentored me and sparked this interest to pursue my training while I was at PMH. And I'm sure you will recognize some of these faces: Dr. Percival McNeil, Dr. Paul Roberts, Dr. Corinne Sinkby Brown, and of course, Dr. Bassett. And these persons were so instrumental in not only getting me to pursue my training, but I recall, especially on rounds with Dr. Sinkby, that we had a GI patient who was post-repair of biliary atresia. And I think that was where my love for GI was born. And so I just had to say a special thank you and make some recognition of those persons who had mentored me so well during my training. Thank you. And so just to get to the business of the meeting this morning, I don't have a whole lot of slides for you. I have no financial disclosures or disclosures of any kind for this presentation. And in terms of what we will discuss this morning, our outline, several people have asked me since I've returned home exactly what is a pediatric gastroenterologist? What do you guys do? And so I will speak a little bit to that this morning, as well as generally talk about why or when you would refer to a peds GI doc. What kind of treatments and services do we provide? And then I will quickly go through some of the common GI problems that you might encounter here in the Bahamas, and kind of when you would want to think about referring them to someone like myself, and what you may need to do prior to sending them over. So essentially, pediatric gastroenterologists are trained in doing diagnostic testing of a child's digestive system, that will involve the diagnosis, treatment, management, and we incorporate growth, maturation, physical and emotional development. We do quite a few diagnostic procedures, anything endoscopies, colonoscopies. In addition to those, we do other types of biopsies, such as liver biopsy, rectal suction biopsies, motility testing, 24-hour probe studies and the like. And then some of our interventional managements will include things like managing bleeding, working with kids who have nutritional problems or special dietary needs. And then liver disease is a part of a general GI doc's forte, but there's also a whole other subspecialty just with hepatology in and of itself. So I won't focus too much on the liver this morning, but I did want to mention that the need for, or the amount of referrals that we've seen have been increasing over the past decade or so. And so the field has certainly grown and expanded, and we're having more and more of these focused clinics to deal with some of the disorders that we do see. And so just based on the number of patients that are being diagnosed and managed, we have now things like a feeding clinic or an abdominal pain clinic, because that's such a big part of what we see in our clinics, celiac disease clinic, even liver clinics, like I said, that's a whole other subspecialty in and of itself. And then celiac disease feeding, and of course the general GI clinics as well. So it's quite a multi-specialty field. And this, of course, would mean that we collaborate with a number of other services and subspecialists, people like our dietitians, our GI nurses, pediatric surgeons, we work very closely with as well. And so it's certainly not a single effort. It is very much multidisciplinary, right down to psychologists, psychiatrists as needed for some of our GI disorders. So when would you refer to a pediatric gastroenterologist? Some of the symptoms that may bring patients in to see a general family medicine doctor or a general pediatrician are some of these that are listed here. And of course, this is by no means an exhaustive list, but these are some of the typical symptoms that we tend to see when patients are referred to us. And often it's a situation of where, their regular doctors trying to manage and not seem to be making much headway, or the symptoms are persisting or worsening. And then they say, well, okay, let's get you to a subspecialist and see if they can help you any further. And so many reasons why you would refer to us, but I think, of course, we would know that some of the top ones would be the abdominal pains, the constipation, feeding problems, or just chronic issues like diarrhea, for example, chronic vomiting we see as well. And so what are some of the things or the conditions that we are able to manage? And you see here again a list that's by no means exhaustive, but it really is an A to Z list of conditions that we manage and we treat. As they say, everything from the tutor to the rooter. So I tell our patients anything from the mouth to the anus, including the hepatobiliary system and the pancreas as well. It's all part of what we deal with. Now, of course, there are some pathologies that will occur in those areas that will not come under GI. So surgical pathologies we do not deal with. Those we refer to our pediatric colleagues, our pediatric surgery colleagues. But for the most part, these are some of the main conditions that we manage and we treat. And I'm very interested, now that I've returned home, just to kind of see what the landscape looks like here for our kiddos at home. I'm sure the bread and butter abdominal pain and constipation will be there, but very interested to see what would be some of the other GI pathologies that we encounter here in the Bahamas. And so the big one, like I've mentioned before, of course, is the abdominal pain. And for most of these conditions that I'm going to talk about, you'll see that the pre-workup or the pre-referral therapy will be very similar in most cases, with one or two exceptions or one or two minimal differences along the way. So I won't spend too much time on the slides, and it's mainly just to give you an idea. This list is not to be memorized, but just something to keep in the back of your mind when you do see patients who may come in with these complaints. And so, like I said, the demand for the pediatric outpatient clinic in GI is increasing. And a lot of these patients are presenting initially to primary healthcare doctors, but it is important that the triage that's done by their primary docs gives us some guide as to what's going on with the patient. And so the information that we get from you is going to be important, especially in terms of your clinic notes and what has been done so far prior to the referral. And so, for example, with regards to abdominal pain, we see here some of the reasons why you might want to refer to someone like myself. And our presentations can be acute, high acuity, they can be low acuity. Sometimes they're acute presentations, sometimes they're more chronic presentations. And so all of that would be part of what you would let us know, especially with regards to how urgently you need this kiddo to be seen. So in terms of when to refer, we have this list here. And then with regards to the workup or what you might do beforehand, again, all of these will be just suggestions. It will absolutely go on a case-by-case basis. But these are just some possible testing guidelines that may point us towards a suspected diagnosis. And in addition to the workup, there's some other information that we may request or we may ask for depending on what the presenting complaint is. And so some of these studies, again, a lot of this will look the same from condition to condition. However, if you were to call me and say, I have a kid, this is what's been going on, I may say, well, let's go ahead and check the celiac screen, or let's get an ultrasound, just to make sure that we're not dealing with any type of intermittent obstruction or anything along the lines that might warrant referral even to someone else instead. And so, again, nothing to memorize, but sometimes there are some things that can be done prior to the referral that will actually not only give you an answer, but may help to manage and resolve the problem. And so the main things seem to be the constipation. If you manage the constipation, or if they're having a lot of reflux and you get that under control, your abdominal pain might disappear, and then there's no need to send them over to me. However, if you have done the trial of, toilet sitting and getting the constipation resolved, you've put them on the dairy-free diet to see if the lactose intolerance is an issue, you've tried the acid suppression for 2 to 4 weeks, nothing seems to be working, then that's when you would point them our way. And we sometimes do advise our primary doctors to let our kiddos know that you're going to see a GI doctor. This may involve some procedures. So you may end up with an endoscopy, a colonoscopy, and it gives the parents and the patients in some cases a chance to go and learn a little bit about what those procedures are and what we might discuss in the initial clinic visit. So another big one is constipation, and this you would think would be one of the main reasons that GI doctors get referrals. But we found that for the most part, our primary care doctors are very well versed in managing constipation in our kiddos. And so it tends to be the complicated cases that we see in the GI clinics. There are some cases, of course, where you would refer to us a little earlier. So those newborn infants who aren't passing stool, concerned about Hirschsprung's disease. If there are any alarming signs that come along with the constipation, if the kiddo isn't growing as well as you would expect. Ankle creases may be a part of constipation, but in and of itself, it may be another symptom. And then you've tried to manage the constipation, you've done some aggressive intensive therapy, nothing seems to be working, they're actually maybe developing more symptoms or getting worse, then you would say, okay, let's call GI and see what their thoughts are. And again, just some suggested guidelines for prior to the referral. The fecal impaction will mean the rectal exam, as well as a good abdominal exam. And so some kids have come to us and they've had the rectal exam done. If you choose not to do it and you want to wait for the GI doc to do it, I say it's sometimes a good idea to warn the kiddos and the parents that this will also likely be a part of your initial visit. Any kid from newborn all the way up to the young adults that we see, if they come in with chronic constipation, will get a rectal exam. If for some reason it's too traumatizing for them, they just are not able to do it for whatever reason, that might be the one time we would do an X-ray instead. But typically we do not use an X-ray. We prefer to use the rectal exam, digital rectal exam. If the exam is so important and we don't want to rely on that imaging study, we may actually even do an exam under sedation. But for those kiddos who are old enough, or for the parents, it's just a good idea to give them a heads up that this is what's going to happen. And so just, again, they can be prepared for it. Some of the underlying diseases that can cause constipation, such as thyroid disease or celiac disease, it's a good idea to screen for those as well if you can. But again, not necessary. You can send them over to GI and we would be happy to take a look. We always like to remind our referring docs that we want to assess for spinal abnormalities. We want to check the anal tone. Yes, we would like to diagnose things like a spina bifida or spinal cord abnormalities, or even a Hirschsprung's disease in early newborn period, early childhood. However, sometimes the diagnoses can be missed, or the presentation is atypical, and so we don't make the diagnosis until later in childhood. But it's still important that if you're seeing a child with chronic constipation and you just cannot get it resolved with some of the standard guidelines, to start thinking a little bit outside the box and thinking about some of these other conditions that might be underlying. And so the initial management of this can be started from the primary doc's office, or we can start it once they come in to see us. But the mainstay for us once they come to the GI clinic is going to be disimpaction, usually with medication. And we say we sometimes do it from above and below. So oral medication, or your fluid enemas, or your suppository, for example, just to get things started. And currently, our national guidelines, American national guidelines, recommend treatment for 6 months. And then if there has been good resolution of the constipation and the child is able to maintain regular toilet habits, we can say that the constipation is resolved. But it's another issue that we discuss with parents that, you know, if it's a chronic process, it's not going to be resolved acutely. It takes time, and it takes a lot of buy-in from the parents and the child as well, in terms of toilet sitting and toilet habits and going on schedule and taking the medicine. So it can get tedious for them. But again, it's the only way that we will get it resolved. And when we do try to manage the constipation this way and still unsuccessful, we start to become a little bit more aggressive with the diagnostic interventions. And then that's when we would let parents know, okay, we think there may be something else going on. And so we need a little bit more testing and evaluation. Another big one is esophageal reflux. And of course, we know that in the newborn and infancy period, this is very common. We say that 90% of babies will spit up at some point. From the GI perspective, we expect some kids to have reflux up to the age of a year. So in that first year of life, if it is not causing any effect to their quality of life, if they are happy spitters, so to speak, even though they may be bringing up a good volume of milk, spitting up frequently, if they're growing and they have no other red flag symptoms, we pretty much just let them grow it out. However, if over the age of 1 year, they're still having significant reflux, that's when we would start to become a little bit more aggressive in terms of trying to diagnose and then treat. And so if you have a kiddo up to the age of a year who's growing, otherwise doing okay, they may be okay. But if you think it's a little bit more complicated, certainly you can send them to us. I know that parental anxiety is significant sometimes. But definitely, if they're hitting that 12 to 15-month period and they're still having significant symptoms, we would want to see them. And so in terms of workup, for the kiddo under a year, they have the immature lower esophageal sphincter. They're prone to reflux. As they grow, this resolves. So there's not a whole lot that we would do initially unless they're having some red flag symptoms. And then, like I said, over the age of a year, we become a little bit more aggressive in terms of trying to diagnose and figure out what may be going on. And sometimes this may even include doing an upper endoscopy in some of these kids, just depending on the presentation. But one way we would sometimes try to avoid that is to do an upper GI study, just to make sure there's nothing anatomically that we're missing before we sedate them for an endoscopy. Failure to thrive, one of those phrases that I think we're now trying to do away with, just because it does cause parental anxiety when they hear this term. And so we're talking now more about inadequate weight gain or slow growth, delayed growth, and things like that. However, there's so many reasons that our kiddo may be not thriving or growing as we would expect. And so the workup or the investigations, and mainly through your history and physical, may help to point you as to why. You know, you're going to look at the parents and family history as well and all of that. But those kids who, you know, you've tried to improve their caloric intake, you've tried to improve their diet, if you're not making headway, or if you're finding that they are also having red flag symptoms, you know, the vomiting, the diarrhea, fevers, just not responding to dense calories, then you would refer them to GI. And so some of the things that, you know, we would do or you can do prior to sending them over to us are listed here. And then on the right-hand side of the screen, you see some tests there that we would say to consider. Those, you know, we're happy to do in the GI clinic, but oftentimes we do a lot of those testing as well, because we want to look for things like malabsorption, for example, or celiac disease for whatever reason, cystic fibrosis. Less likely in our population, but still something to consider. But I think the big takeaway is that we try to make sure that it's not an organic versus non-organic issue. Again, terms that we're doing away with, but sometimes it's just a matter of availability of food, or parents not understanding proper feeding techniques, or they are, some parents have already mentioned to me that they've been diluting formula because they're concerned about the shortage. So things like that. And so it's important that we have height and weight data for these kiddos, and then to really do a deep dive into what's going on psychosocially with them as well. And that's where we start. But we try to avoid any aggressive testing, unless absolutely necessary. And oftentimes, even before the testing, we would admit these kids to the hospital, feed them in the hospital, see how they do. Oftentimes, you find that once you put them on a strict feeding regimen, they actually will start to gain weight during the admission. And so then you educate the parents, you send them home and continue to monitor them very closely to make sure that they have continued weight gain. Some of the kids that we see actually are not able to feed orally, whether for a temporary period of time or for a prolonged period. And so they have gastrostomy tubes in place, and those we would manage as well. I think I do know of 1 or 2 kiddos who are here who are on that list as well. But this is one of the reasons why the feeding clinics have been established in some places, because we do have so many kids who are coming in with food sensitivity issues or all aversion issues, just difficulty feeding. And again, once you've done that deep psychosocial dive, you find that it's more than just not having the food or parents not providing it in a proper manner. They have everything they need, but for some reason, the patient may just have an aversion to certain foods or to certain textures or consistencies. And so this is where we would bring in everything from feeding therapy nurses. We have psychologists, psychiatrists to work with a lot of these kids as well, especially for oral aversion. And they work very closely with the parents to try and not only stimulate the appetite, but to help with the motor development of feeding as well. Diarrhea. So this is a little bit more concerning for most parents. If a kiddo starts to have diarrhea, and we can understand that this can cause significant issues as well, especially if it's going on for a prolonged period of time. And I've listed here again some of the symptoms that you would want to find out about, which may again allow you or prompt you to send them to GI. But certainly you've tried, some manipulations at home. But if any of these signs or symptoms are mentioned, then I think we would certainly appreciate a call at that point. This one didn't come out so well, but the main takeaway from this slide is that, of course, your stool studies are going to be primary importance. We want to know, rule out infection or make sure there's no blood in the stool that may not be obvious to the eye. And then there are some other studies that we can do looking for things like malabsorption, or we would also want to check for other underlying conditions as well. And so some of these kiddos will get an upper GI study with follow through. The one thing I do want to mention is that sometimes we do have kids who come in who are taking laxatives for a number of reasons, and that may be the reason for the diarrhea or increased stool output. And so that's something to keep in mind, as well as overeating, especially in that tween age group. We find quite a few kids who, once you do that deep dive into the dietary history, they're simply consuming too much. And so it's prompting the increased stool frequency. And of course, again, with anyone with chronic conditions like this, we want to know and chart their growth. Prior to the referral, there are some things that you can try and tweak, especially with the diet. We always recommend increased fiber for these kids. We often do a trial off of dairy, strict dairy-free diet. And we often have to spell out for the parents what that means. But once you've done that, and oftentimes we've had parents come in who said, okay, I had them off dairy for 2 weeks. I took them off gluten for 2 weeks. No change, no improvement. Mom, how much juice are they drinking? So it's really important to get that history and to go into deep dietary details with some of these kids. Blood in the stool, another concerning symptom that probably would prompt a quicker visit to the doctor. But again, there can be any number of reasons why a kid might have some blood in the stool, but there are some red flag signs that we are looking out for and that we would want to know about sooner rather than later. Here, I want to point out that the family history of inflammatory bowel disease, colonic polyps is important because oftentimes colonic polyps in our kids will present with bleeding, and the bleeding is intermittent. And so, parents see it 1 or 2 times, they think nothing of it, but then big sister mentions, oh yeah, I saw some blood in his diaper. Dad, when he changed, also saw some blood in the diaper. Mom saw some blood in the diaper, but they never realized that they were all seeing blood. So that's important to know as well. But again, some of these kids will ultimately require colonoscopy or a flex sig at the least. And that's something we would discuss with the parents, but this is something that will prompt an early referral to the GI doc. And here again, your workup is going to be a little bit different in that the stool studies will of course be very important, but now we're going to want to know more about our labs and the PT, PTT. We want to know what the hemoglobin is, how much blood is this kid actually losing, and we probably are more likely to do an upper GI series in a kid with chronic diarrhea, rectal bleeding, and a colonoscopy if it's persisting despite investigation and management. And then of course the bloody diarrhea or colitis is going to prompt early studies and management. And here again, it's similar to what we saw on the last slide, but number one here is going to be infection. And so we tell parents as well that, the diarrhea itself, we will monitor, we will make sure that the bleeding is not significant. But sometimes infection can cause some blood. And so we would allow sometimes for the infection to clear, treat where treatment is appropriate. And then if it persists, then that's when we actually have to go inside and take a look via colonoscopy. Vomiting. And so vomiting, like abdominal pain, nausea, it's on that spectrum of the functional GI disorders that we see. Sometimes there are things going on with the patient that will manifest as vomiting or as abdominal pain or nausea. And it's often difficult, as with abdominal pain, to sometimes manage these kids because it's not necessarily vomiting due to a physiologic reason, but like I said, other things going on that may be precipitating a reaction through vomiting. But of course, there are some cases where we would want to see them sooner rather than later. And any of these signs or symptoms, if present, would also prompt GI referral. The history of the foreign body or the caustic ingestion of pills, of course, would be a little bit more emergent. And even dry swallowing of pills sometimes as well. And cases like that, with dysphagia, for example, we're going to want to go in and take a look and do an upper endoscopy on those kids. And so sometimes that's something that we would advise parents as well prior to them coming to us, that we will be discussing this procedure. In terms of the workup, you're going to be guided by the presentation. You're going to be guided by the acuity, what's coming up when they vomit. Is there blood? Is there bile? What does it look like? How often does it happen? And then how is the kid between episodes of vomiting? Are they able to eat and drink? Are they growing? Are they gaining weight? You see on here amylase and lipase. So pancreatitis, if you have a concern, it's going to be a little bit more emergent. to get them assessed, but you will be guided by the patient in front of you in terms of the workup, because there's so many different things that can cause a kid to vomit. Liver disease, I will touch on briefly. We do see liver patients. I'm not sure what our incidence will be here in the Bahamas, and that's one of the things I'm very interested to find out. However, any of these signs or symptoms, any of this evaluation, if you're getting these results, then that's the time to call a GI doctor. We don't want them to look like this kiddo in the picture, but your acolic stools, for example, in your infants, your babies, your newborns, elevated billy levels, especially beyond 3 to 4 weeks of age, we would want to know much sooner rather than later. And then here you'll see that, of course, your liver enzymes are going to be a little bit more important, your biliary enzymes, coagulation studies as well, and abdominal ultrasound is pretty standard as well. Anytime you're dealing with jaundice or any suspected liver pathology, it's non-invasive, it's usually pretty easy to get, and so it's often a starting point for any patient who presents with liver disease. Celiac disease, I don't know what our incidence is like here in the Bahamas, but if we do come across patients with some concern for celiac disease, there are markers, serological markers that we can follow and use for diagnosis. Our confirmation of diagnosis comes via endoscopy and getting some tissue for a biopsy. However, these are some of the presenting signs and symptoms that you may see, and celiac disease is closely associated with diabetes type 1. And so it's one of those screenings that's recommended anytime you have a patient diagnosed with diabetes type 1. We know that celiac disease is due to gluten sensitivity, and so oftentimes parents will tell the patient, parents and some primary care doctors as well will tell the patients to stop all gluten ingestion to see if it affects their symptoms. But for testing and evaluation, it's actually important that the kid is on gluten. And there's actually a prescribed amount that's recommended. And so if there is concern for celiac disease, or if you have a kiddo with type 1 diabetes, let them continue the gluten. We'll try to manage their other symptoms supportively, things like the abdominal pain and so forth. But we need them to be on gluten when we do the testing, especially the endoscopy. And so these are some of the testing and evaluations that you can do, simply because their symptoms may be due to other conditions as well. But that serum IgA and the tissue transglutaminase antibody are the primary markers that we're looking at. And then we just want to make sure that there's no other cause for their symptoms, infection, and so on. And then just a brief mention about things that are considered urgent referrals. And again, not an exhaustive list, but these are some of the more common ones. Again, I go back to the acolic stools that we see in our babies, jaundice or hyperbilirubinemia beyond 3 to 4 weeks of life, your elevated liver enzymes, and then ingestion of a foreign body. Anything in the esophagus is usually considered pretty urgent. Unless the patient is so comfortable that it doesn't seem like he will deteriorate or decompensate on you quickly. But anything on the list here is something that you would want to have assessed sooner rather than later. And so just to kind of wrap up, I have here on the left side just a list of some of the common complaints that are seen that would prompt you to refer to GI doc. And then we also have on the right the list of the more urgent complaints or presentations. Again, by no means exhaustive. And if ever you have a concern or you just want some clarification, I'm happy to just do a telephone consult or curbside consult. But when you are, if you do have a concern, then by all means, it's better to err on the side of caution and just reach out. And I will say that, when we see these patients, once we can get them pretty well controlled or managed, get their condition resolved, we send them right back to their primary doctors, where we don't continue to see them as general pediatricians. We want to manage their GI issue and get them back to your service. And so sometimes it's not necessarily curing, but if we can get them well controlled to the point where you as the physician are able to continue the management, then we are happy to send them back to their medical home. And just when you do refer to us, some of the things that we would like to know, I think the documents is the big part here. We want to know what the growth charts look like, if you've done any investigations, and then any relevant clinical notes or findings that you have. And I've just included here my name and email. I'm currently at Pediatric Associates with Dr. Carlos Thomas, but feel free to reach out by whatever means. And if you have any questions or concerns, I will be happy to address them for you regarding your patients. And I think that's it. Thank you all so much for your attention today and for joining us. Again, I'm very happy and very honored to be able to do this brief introduction and look forward to meeting a lot of you in person real soon.
Thank you so much, Dr. Darville. That was wonderful. And while we wait for people to get their questions together, I have a couple. So I'm going to start.
Sure.
I'm going to start, and hopefully people will either put their questions in the chat or, Dr. Halliday, I don't know if you're going to allow people to unmute and give their questions, but I'll get started in any case. So Dr. Darville, you hit on the things that bug us most as pediatricians. I have two that I really want to ask you about. The first one is about constipation, and you made a point to say that you don't diagnose constipation using an X-ray, and that's like something that parents always want to see what's on the X-ray. In the Bahamas, I find that a lot of parents love using enemas for their kids who are constipated, so that always poses a diagnostic dilemma for us, because they come in with abdominal pain. The parent will say, oh, they go to the bathroom every day. I don't think they're constipated. You do the rectal exam, you may not find anything. What's your next step if you're thinking constipation but you have a negative rectal?
Right. And oftentimes I find that the abdominal exam, if a kid's impacted, you will feel those stool masses in the abdomen sometimes. And that will be a clue as well, because we do have some kids who will go every day, and then you find that they're just passing small little pellets once a day, but they're still pretty backed up. In that case, if I do suspect, and if they're not passing stool, the enemas haven't worked, I think I would try attacking it from above. So we would do some oral medications, an aggressive bowel clean out. However, we do need to know that the kid is able to stool. So if they're telling me that they are getting stool out, no matter how small, I'm less concerned about obstruction. But if, there's anything concerning maybe some distension or firmness, or I do the rectal exam, I'm not feeling anything, but they have a good sphincter tone, there's no reason why they shouldn't be able to pass stool, then I may do an X-ray just to get an idea of the burden and to make sure there's nothing else going on as well that might be contributing to them not stooling regularly. But we tell parents that the X-ray is to rule out anything else more so than to diagnose the constipation itself. You do an X-ray, an abdominal X-ray, you're going to see stool. And some kids will have more stool than others. The stool is in the colon, it's where it's supposed to be. But so we don't like to use diagnostically, but sometimes you do have to. There's some kids who the thought of a digital exam will just traumatize them so much that then, yes, you just go ahead and do an X-ray, or depending on the level of concern, then you arrange for them to be examined under anesthesia.
Okay, great. Thank you. Dr. Chisholm is asking, are you performing any endoscopies yet?
Not as yet. Not as yet. We're still sorting out all of the logistics of licensing and making sure that we have equipment small enough for our younger kiddos. I've looked at some of what is available, and I think we're fine for our bigger kiddos, but I myself am not doing them just yet, but aggressively working on it. And in the meantime, we do have adult GI docs who have been managing our kids. So if there's something that needs to be done urgently, it can be, certainly.
Great. My other question is about reflux, especially in babies. And parents are obsessed with reflux, and they change formulas like a million times. You'd see a 2-monther who's spitting up, and by the time they come back at 4 months, they may have gone through 4 or 5 formulas. So I want to ask you, you didn't mention, but what in your opinion is the role of PPIs and reflux in babies?
Right. So again, we try to avoid in our younger kiddos, especially if possible. It depends on the degree of the reflux. And just to the point about the formulas, we advise parents, against switching formulas too often, especially without giving them a chance to work. Parents have, after 3 to 4 days, they've switched to a new formula. And not only does the reflux continue, but now you're at risk for constipation as well. And we find that as they switch formulas, they are buying more and more expensive formulas because now they're going to more hydrolyzed formulas. And so the kid is spitting up dollars, basically, because it's still coming out. And so there are some cases, especially if the infant is not growing well, if they're having symptoms of fussiness or anything that looks like they may be at risk for aspiration, then we may go ahead and try a PPI at that point. But it's often almost the last resort. We try to do aggressive anti-reflux measures. Sometimes we would recommend some formula change, but we tell parents not to do it on their own. We like to try and guide them through it. And if, for example, they're on an extensively hydrolyzed formula and still spitting up quite a bit, then we may consider medication at that point. And it's typically an omeprazole, so it would be a PPI.
Okay, I see Dr. Ruth Dorset has her hand up. Go ahead, Dr. Dorset, and then I have a question from Dr. Sinqui after.
Good morning. Welcome back. Good to have you back. My question, the patient that comes in and recurring abdominal pain, you've done just about every workup that you can, and so you want to kind of wind this down to maybe something psychological. What are your thoughts on that sort of patient?
Yes. So probably one of the most difficult areas, especially, as the patients are getting older and they're able to express their symptoms and they are watching their parents react to their symptoms. And so it becomes this cycle. Parents are stressed, and so the kid becomes stressed as well about what's going on. And often in those cases where you have this refractory abdominal pain, they do receive the so-called $1 million workup. We will scope those kids, often just to go in and make sure to show parents that we've done everything in terms of investigations. We cannot find everything wrong. We've looked, we've taken tissue, we've tried medications. And so we've circled back now to, could this be something we call functional? And that's a conversation that we actually start very early in their visits. We give parents that broad list of what could be going on to cause the abdominal pain, and we always include functional. And as we're going along with the investigations and we're working these kids up, we say, Mom, we've done X, Y, Z. We're going to go ahead and do this investigation. But if everything is normal, we're most likely looking at a functional cause for the abdominal pain. And then we start to try and tease out even more thoroughly what could be going on to cause it. But the most important part of it is to have the parents buy into it, to have the patient buy into it if they're old enough, and to begin to work on some of the things, the external things that might be causing dysfunctional pain. There are medications that we sometimes use in those situations, but they come with side effects, which we discuss, thoroughly with parents. But it's a conversation that sometimes you need to have over and over and over, and parents often will be resistant to it until you've completed all of the workup and you find nothing wrong. And so, we've already been talking to them about possible counseling or psychology referrals or psychiatric referrals, depending on the need. And so it's not kind of okay, we've done everything, we think it's functional. We start that conversation from very early in the visits with the GI docs. But it's tough. It's very tough.
That is a good one, and one that, is difficult to manage. Let me go to Dr. Sinqui's question. She's asking, first she said, welcome home to Dr. Darville. Please advise on the newer tests to check for blood in the stools beside the guaiac, when to use these, and the approximate cost.
Oh, now the cost is going to be tough. I will say that I'm not sure about the cost for some of them now, but in terms of blood, you should say blood in the stool, correct? Sorry, yeah. Can you hear me okay? I think I lost you, Dr.
No, yes, that's
okay,
what she's
okay.
Blood in the stool.
Okay, yes. So they do have some newer tests on the market. For the most part, we were still using the guaiac testing and the hemoccult card testing, but I think part of the issue too is just sometimes with the turnaround time and the processing of samples, it's a little bit trickier as opposed to just putting something on a card. And I'm not sure what is available here. If we do have it, to begin to speak to the cost, that's something that I will have to look at. But yes, if it's available, that's also something that we can do here. It's just, I think, making sure that the processing is done adequately is going to be the big issue.
Okay, are there any other questions for Dr. Darville? Check the chat again. I don't think I see any more. And or maybe one question, I do want to say that the code to claim CME is PMH-CME. PMH-CME. And Dr. Halliday has in the chat how to get to the link in order to do the feedback as well. Okay, any other questions for Dr. Darville before we go? No. Okay, one more time, the code to claim CME is PMH-CME, and Dr. Halliday has put the link.
Sorry, the code is Life Learner. The Zoom here is PMH-CME. So.
Sorry, that's what she said. My apologies. All right, so in the chat, Dr. Halliday has put the key Life Learner on the Sunshine Learner site. So you can go to the Sunshine Learner course, and the enrollment key is Learner. Okie dokes. If there are no other questions for Dr. Darville, I'm going to say thank you very much, Dr. Darville. It was great to hear you this morning and to hear what kinds of services you can offer us in pediatric gastroenterology. We look forward to seeing a lot more of you and being able to refer a lot of our patients for these issues that have been given us difficulties. Oh, Dr. Daniil has a question before we go. Last one. Dr. Darville, she's saying, welcome back. And what is the long-term treatment for EOE? I'm thinking that's eosinophilic esophagitis. Dr. Darville, you're still there?
Oh, hi, can you hear me?
Yes, I can. Go ahead.
Oh, there we go. Thanks, Dr. Williamson. Yes, EOE. So there are quite a few therapy modalities that we use. I think the primary one will be the PPI, like the omeprazole. That's typically where we start. If possible, we try to find what are the triggers, especially dietary triggers, and to eliminate those from the diet as well. And then if they seem to be refractory to a PPI, a swallowed steroid, like a budesonide, sometimes is needed as well. And again, there's the 6-food elimination diet, which is a little bit more difficult. If we're not able to identify a specific trigger, there's the list of the most common food allergy triggers that we, in varying combinations, we can eliminate those from the diet. And what happens is every time you make that intervention, then you have to rescope the kid to see if there's been some improvement. So the long-term management will be either your PPI, your dietary eliminations, or swallowed steroids, followed by scoping on a regular basis to make sure that they're improving.
Okay, thank you very much. I think that was the last question because we're at 9:02. So thank you again, everybody, for attending the meeting this morning. And thank you so much, Dr. Darville. We hope to see a lot more of you. Have a good Friday. And we'll see you again in 2 weeks on a Wednesday for CME. Have a good day.
Thank you all. Bye-bye.
Thank you very much.